And I am speaking from the Museum of History of Ideas in Manila. Ajak Powers Punta Manila. Welcome to all our participants. Today's interesting topic is HPV infection, what you should know. The objectives of today's webinar are to review HPV disease, burden, and epidemiology, to describe screening and prevention tools of cervical cancer, especially in developing countries like the Philippines, to give updates on the efficacy of HPV vaccination, to describe global impact of vaccination including local impact, project the future direction of cervical cancer prevention. Today's speaker is Dr. Ricardo Manalastas Jr. He is a graduate of the College of Medicine class 1982. He had his residency in obstetrics and gynecology at the UPPGH. He had his fellowship in infectious diseases also at the UPPGH. He had his master's degree in science and bioethics. He is also the founding member of the Philippine Infectious Disease Society of Obstetrics and Gynecology. Currently, he is the Vice Chair for Graduate Affairs of the Department of Obstetrics and Gynecology, Philippine General Hospital. Without further ado, may we now call on Dr. Ricardo Manalastas.
Thank you, Ricardo, and afternoon to all of you. It's both a pleasure and a privilege to be in the webinar to talk about HPV, what we need to know about. Just some disclosures before I proceed with the presentation. And this will be the outline of the presentation. Alright, just as an introduction, the human papillomavirus or HPV is a small DNA virus. Typically, it infects epithelial cells, whether they're cutaneous, which are keratinized cells, or mucosal cells found in the mouth, the throat, and the respiratory tract, and more prominently, the anogenital tract. What is important to realize about this viral infection, in contrast to other viral infections, that there is no significant viremia as far as HPV is concerned. It says several implications as far as the immune response, as well as the possession of cervical cancer and many other cancers in the genital tract. There are more than 100 types of HPV. 40 of them are anogenital, meaning they are confined to the anogenital area. And what's the main indicator of concern as far as these 40 anogenital types are the 14 or so-called high-risk HPV types, which we'll show in a little while. These high-risk types, they vary in both prevalence, persistence, and most especially as far as virulence is concerned. The more virulent types are those that are associated most commonly with malignancies, typically cancer of the cervix. And above all of these high-risk types, the real bad boy, so-called type 16 or HPV 16. Which is the most virulent, followed by HPV 18, 31, and 33. As the next slide will show, there are other high-risk types. It's also important to recognize that these types contribute to different cancers, not only of the genital tract, but postulated also of cancers in the oropharyngeal area. There are other types, of course, the low risk, so-called low risk types, most prominent of which would be types 6 and 11. Typically, they would be because of what we call the anogenital worms. Um, right? HPV infection is transmitted by direct skin-to-skin contact. It is known that microabrasions in the skin are necessary for the virus to gain entry into the epithelium. Um, when we say skin-to-skin contact, we of course refer to being the most common sexual contact. The sexual transmission of this HPV is not limited to genital penetrative sex, but also to oral, digital, and anal sex as well. It is theorized, but that would be rare, that fomites or inanimate objects can also be the mode of transmission of this virus. This slide shows to you the natural history of what we call the high-risk HPV infections and their progression to specifically cancer of the cervix. As we'll discuss later on, it is cancer of the cervix that is the greatest burden of disease as far as HPV types are concerned. So, this slide I think is important, and we'll spend a little more time with this. After an initial HPV infection, about 80%, given enough time in a immunocompetent host, about 80% will just clear, so-called clear the infection will just go away. However, a small percentage, maybe as much as 10 to 20%, will go on to become persistent infection. And this is defined as infection with the same HPV type for at least 6 months. Typically, they would say as long as 12 months. And it is this persistent infection that can later on go to what we call the cervical intraepithelial lesions, or CIN1, as well as CIN2 and 3, the more advanced lesions as far as the cervix is concerned. Oops, sorry. Let me try to go back. As you can see from the diagram, again, CIN1 can also spontaneously resolve in majority of cases, spontaneously clear. And it is CIN2 and 3 that we are really are afraid of. And we'll talk later on about how CIN2 and 3 can subsequently develop into cervical cancer. It is postulated as well that the presence of HPV, along with other cofactors, along with other cofactors like host factors and other environmental factors that can facilitate the conversion of CIN2 and 3 to cervical cancer. By the way, CIN refers to cervical intraepithelial neoplasia. Right? And notice also that it takes many years from infection, from initial infection, to the development of cervical cancer. It takes a while for this to happen. So this is the natural history of high-risk cervical cancer. Now, how does malignant transformation occur? Just to keep it short, it is the E6 oncoprotein that binds with what we call a cellular protein, what called P53, together with the other oncoprotein, which is E7 of the virus, that binds with another cellular protein, PRB, retinoblastoma protein. When this happens, when this binding occurs, usually in persistent infection with the high-risk oncogenic types, that's when the other cellular metabolism, disruption of the other cellular metabolism occurs, leading to tumor formation, and therefore cancer subsequently. Right? So this would be the natural history. Let's go now to the burden of HPV disease. As we mentioned a while ago, the greatest burden would probably be on cervical cancer cases. HPV 6 and 11 accounts for, no, HPV 16 and 18 rather, accounts for about 70% of cancers of the cervix. Again, that is important to keep in mind when we talk about prevention with the vaccines. The burden is not limited to cervical cancer. The vulva, the vagina, the anal canal can also be involved with HPV infection, subsequently developing cancers as well. Although admittedly, the greatest burden, again, is on cancers of the cervix. There are other burdens, not necessarily malignant, like the low-grade cervical lesions, and more commonly the genital warts. And HPV 6 and 11 accounts for about 90% of genital warts. Now, this table is rather a busy table, prematurely comparing the disease burden due to 4 HPV types, the 4 most common, and the next most common 9 HPV types, which includes the 5 next most common high-risk types. And therefore, if you have all of these 9 taken together, the burden of disease further increases. And just to illustrate, from 70% of cervical cancer cases, it rises to about 90%. Right? Keep this in mind when we talk later on about the new generation vaccines that we currently have as far as preventing these 4 types versus the 9 types that are a burden. In the Philippines, invasive cervical cancer is generally due to HPV 16, related to HPV 16, as well as HPV 18. And this slide illustrates the contribution of the other high-risk HPV types, right? So that if you can prevent infection with HPV 16 and 18, this would be the number of cervical cancer cases that you would prevent. The idea is prevent HPV infection, interrupt the progression to cervical cancer in the future. These are the top 10 causes of squamous cell cancer in the Philippines of the cervix. Again, 16 is the bad boy, followed by 18, and then 45, and so on. So this is for squamous cell carcinoma. We go now to some aspects about epidemiology. How common is HPV infection? It is estimated that not all, but the majority of sexually active men and women will at one time get at least one type of HPV infection. The good news, of course, is that the majority will just resolve in about 80, maybe even as high as 90%. The problem is most of those who get infected, because of its self-limited nature, most would not know that they have the virus. The bad thing, of course, about it is if they get the high-risk type of the virus, like 16 and 18, they have a more predisposition to persist. And as you recall, it is persistent infection that can subsequently lead to the neoplastic changes and therefore cancer. What is the epidemiology of cervical cancer? It is estimated that more than 6,000 Filipino women are diagnosed annually, so new cervical cancer cases. Second to breast, it is the most common cancer of women in the Philippines. It is also the second killer cancer among women in the Philippines. The sad affair is that most cases are diagnosed in the advanced stage, and therefore the prognosis would be a little dim for these patients. It is estimated that the cost of treatment of cervical cancer in the Philippines will range from about 150,000 to as high as half a million, depending on the healthcare provider. So indeed it is a burden. Now let's go to how we can protect ourselves from infection with HPV and the subsequent diseases that they cause. Healthy lifestyle, total sexual abstinence, because this is a predominantly sexually transmitted virus and disease. Lifetime mutual monogamy, of course. Barrier methods of protection, like the condom, whether it's male or female. Circumcision has also been known to partially protect. Screening is a secondary preventive method, like the pap smear will detect the early precancerous lesions, at which time treatment can be instituted. And of course, we've had for the past 10 years, the HPV vaccines that are available. In fact, we have the second generation vaccines, which we will now subsequently discuss. Just some development milestones as far as the vaccines for HPV are concerned. It was in 2002 that the phase 1 and 2 clinical trials for the quadrivalent and even the bivalent vaccine were started. And it was in 2006 that the vaccines, both vaccines, at that time, they were approved for use in several countries, including the Philippines. So it has been a little more than 10 years since we had these vaccines available. The bivalent vaccine, the bivalent because it contains antigens against 16 and 18, is typical, it's regulatorily approved for cervical cancer, for prevention of cervical cancer in women. The quadrivalent vaccine, which contains antigens against 16 and 18, the oncogenic types, but also against 6 and 11, the causative agent of the genital warts, were approved, was approved regulatory-wise for prevention of cervical cancer, vulvar, vaginal cancer, and anal cancer as well for women, cervical cancer, anal cancer for men as well. Anal as well as penile cancer, for men. And of course for external genital warts for both sexes. In 2015, just almost a little over a year ago, the 9-valent HPV vaccine was approved in some countries. So from the bivalent, the quadrivalent, and now just very recently, the 9-valent vaccine has become available as well in our country. The additional 5 high-risk types were added, types 31, 33, 45, 52, and 58. So the addition of these 5 other viral types has expanded the coverage, the protective coverage of the vaccines to more cervical cancer cases, vulvar and vaginal cancer cases as well. Right. All of these HPV vaccines, they have been proven clinically efficacious, practically approaching 100% in preventing infection with in the HPV vaccines that are contained in the vaccines. HPV types that are contained in the vaccines, when administered to HPV naive individuals, typically these are the 9 to 15-year-old girls and boys. So highly efficacious vaccines. In a cohort of women in the Nordic countries, such efficacy has been evident for the past 10 years already. So these women who have been given the vaccines ahead of any other population has shown that 10 years after vaccination and counting, so 2002 and 2007, there have been no breakthrough cases due to the vaccine types that are in the vaccine that were administered to this group of women. In the real world setting, it has also been proven, the experience has been 10 years already, the clinical effectiveness of these vaccines is impressively significant as well. So these are before and after comparison. So that's why we call them effectiveness rates. So in Australia, where there is 80% coverage, there is an effectiveness of anywhere from 75 to 94% in reduction of external genital warts, up to 51% reduction in precancerous cervical lesions. In the USA, in the United States, a 56% reduction in the HPV types in the vaccine, so that's infection, and a 40% reduction as of 2016. So significant reductions in the incidence not only of infection but also of disease. For example, there has been a 60% decline. The effectiveness is from 55 down to 23% in the US, a 60% decline in coverage for CIN2 plus and adenocarcinoma in situ in the US. So about safety. Safety has become a concern for this vaccine due to isolated reports of side effects. However, safety monitoring boards by neutral regulatory bodies have confirmed that these safety issues such as chronic regional pain syndrome, POTS or postural orthostatic tachycardia syndrome, and even of premature ovarian failure. These specific safety issues have been investigated by several safety monitoring boards, including the WHO, the World Health Organization, Global Advocacy Committee on Vaccine Safety, and their most recent statement on the safety is that they have not found any safety issue that would alter their recommendation for the use of the vaccines. So the WHO continue to recommend the deployment. Now, obviously, the challenge is to deploy the vaccine to those who would benefit the most from it. All over the world, it is publicly funded, school-based mass vaccination programs that is supplemented by clinic-based reimbursable deployment that has been proven to be the most efficient. Unfortunately, not all countries, including ours, have embarked on such programs, school-based mass vaccination. If we are to look at our Philippine deployment of these vaccines from 2006 up to last year, this by a crude calculation, about 1.2 million doses of both the bivalent and the quadrivalent vaccine combined have been deployed. If we presume that there are about 31 million females aged 9 to 50 years old eligible to receive the vaccine, a simple calculation would show that only about 3.5% of eligible recipients would have received at least just one dose. The regular recommended dose is to receive anywhere from 2 doses, depending on the age group, to the standard 3-dose regimen. So this 3.5% coverage is relatively dismal as far as vaccine coverage is concerned. It is estimated that we need to cover about 70% of the eligible population in order to have an impact, a great reduction in the incidence of cervical cancer. So if we are to target 70% at the rate we are doing, 3.5% every 10 years, again, another simple calculation would let us to believe that it will take us about 120 years before, at the rate we are going. So we say that we need to do better than this. And this challenge has been taken up, fortunately, by the Department of Health. This is a summary of the story, our Philippine story, of introducing HPV vaccine in the National Immunization Program. In 2011 and 2012, the DOH has embarked on what we call a mother and daughter initiative. They call it the mother for screening together with the daughter for vaccination. This was a successful program. A pilot study was done based in Cebu and in southern Tagalog, where acceptance of the vaccine for this population of about 30,000 young girls was about 95 to 97% completion of the 3 doses. Very successful. And so the DOH in 2013, the Department of Health embarked on what we call a school-based HPV vaccination, targeting about 300,000 young girls. So unfortunately, at that time, this school-based program, proven highly effective, was shifted to what we call a community-based program, local health center-based. Was not as successful as 95%. So it was only about 77%, but still acceptable. Still acceptable. Encouraged by this 77% success rate, they are now ready to embark on a wider scale, targeting almost 800,000 young girls in more than 40 provinces, 40 of the most economically deprived provinces. Unfortunately, though, it cannot yet be a school-based program. Hopefully, by this year, when in the presence of new administrators like the Secretary of the Department of Education, they will again try to employ or deploy the vaccine in schools again, so that they will again approximate 95 and higher percent. So they will expand this hopefully to a school-based program rather than a community-based program. So after 10 years, we are one foot is already in the door. So what is next? This would be the almost last slide, I think. Ideally, we should go for a school-based program headed by the Department of Health in collaboration with the Department of Education. The Department of Health has its infrastructure ready to deploy the vaccine. Hopefully, the Department of Education will agree to deploy the vaccine in schools. That would be more efficient. This deployment, of course, is in public schools. How about private schools targeting young girls and boys 9 to 15 years old? Hopefully, we can engage the health management organizations, the insurance to include HPV vaccination in the healthcare that they subsidize. That will expand it to the private sector. And because we think school-based programs are the way to go, engage also the private parent-teachers associations. And of course, reinforce the role of professional medical societies and other professional groups in deploying the vaccine. So that hopefully we can achieve 70% coverage for the eligible population in less than 120 years as we initially computed. What is recommended now is, along with vaccination, to continue the screening program, at least against cervical cancer, hopefully develop technology to screen for the other cancers in the genital as well as the oral cavity. Right, so this ends the presentation. Thank you again for the opportunity to present.
Thank you for that comprehensive lecture, Dr. Manalastas. We would like to would like to thank today's sponsor, MSD. We now have more than 100 people logged in to go to webinar. So before we proceed to the question and answer portion, we would like to call on our Catherine Ricardo. She is a member of the College of Medicine class 1992. She had a residency in obstetrics and gynecology in GH. She had a fellowship in HIV and HPV infections at the Brown University, Providence, Rhode Island. She also has an MBA degree from the Graduate School of Business. At present, she is the chair of the Department of Obstetrics and Gynecology at the Medical City South Luzon. She's also the head of our Health Center Incorporation and the head of the Making and Announcing Foundation. They will now call on Dr. Catherine to give her reaction. Thank you. It's nice to be amongst colleagues. It seems like it's just 10 years ago since we were at work. Anyway, it's interesting to talk about the human papillomavirus because if you talk about it, some physicians or even paramedicals can even say human papillomavirus. And it's true that a lot of people don't imagine that it could happen to them, that they wouldn't contract the disease, but data has shown that we would be able to contract at least one sometime in our lifetime, and hopefully we'll be the ones who will clear it. But unfortunately, there is no way to really know it. So aside from what Dr. Manalastas was talking about in healthy lifestyle, monogamy, and preventive measures and screening, there is a lot of progress for the past 10 years. And we remember how the vaccines were received when it was introduced. Because a lot of people associated the vaccines as giving permission for promiscuity, and there were some side effects that they were having problems with. But after 10 years, we have established the safety and the effectivity of the vaccines that are commercially available to all of us. Unfortunately, as Dr. Manalastas has emphasized, there is really a very, very low coverage of vaccination in our country. It is staggering because if you think about it, a lot of people say it's because of the cost of the vaccine. But when I talk to my patients, I tell them that your cell phone is actually more expensive than this vaccination, and it can prevent you from spending as much as $500,000 to $1 million once you develop the disease. So a matter of education is very important, plus the support that we can get from government institutions as well as HMOs, as Dr. Manalastas was mentioning, would be very good. There are efforts for some corporations to actually help their employees with vaccination costs, but still we do not find ample usage of the vaccines as of yet. But as progress is going forward in terms of increasing our effectivity to 90% for the non-related vaccines, we see the promise of actually incorporating programs, not just in schools, communities, probably some foundations will push for its use and private physicians. When we give talks around the country and we ask the community actually, how many of you have completed your vaccination? It's very interesting to know that not all physicians are complete with their vaccination. So much of our advocacy would be to practice
ethnic reach. And the data is very, very good, and the data is very, very promising. So hopefully we can even go further and go for a possible law that can ensure our children from having this protection much the same way as we do our hepatitis B vaccinations for newborns. So thank you, Dr. Manalastas, for a very, very comprehensive and encouraging talk on vaccinations, and hopefully this will spark drives from our medical community in supporting prevention of cervical cancer in our country. Thank you.
So we will now be asking, addressing the questions given to us. So the first question is, if I have received complete vaccination using the bivalent vaccine, and there's a new one coming out, the non-valent, can I still get the non-valent vaccine? Dr. Manalastas.
Right. Thank you for the question. It's not an uncommon question. Someone has received either the bivalent or the quadrivalent before, and now here comes the 9-valent vaccine with broader coverage. The question is, can you still get the new vaccine in broader coverage? Yes, a study has been done and continues to be monitored as far as both safety and efficacy of getting another vaccine, HPV vaccine. They know it's safe. If you've been given either the bivalent or the quadrivalent before, what the 9-valent will do for you is to boost your immunity against the types that were given to you before. And it is known, it has been established that the added antigens in the 9-valent vaccine will not interfere with the efficacy of those other factors. So there is no immune interference, in other words. The main question, I think, is whether or not it will be cost-effective or cost-beneficial. The quadri and the bivalent will protect you against about 70% of cancers of the cervix. And if you're naive to all of the 16 and 18, 16 and 18, that is practically 100% protection, 70% of the time. But if you were given the 9-valent because of the additional 5 high-risk types against which you are protected, the other benefit is an additional 20% coverage, 90%. So it becomes a cost-benefit analysis. Are you willing to spend for the 3 doses of the 9-valent vaccine to get that incremental protection? So it becomes a self-decision, not decision for yourself. If you're willing to invest in that, then by all means, yes, go ahead and get the 9-valent vaccine after either the bivalent or the quadrivalent. Which should lead us to the question is, how much is the 9-valent vaccine right now? So I don't know if you want to look at it. So we'll
Yes. Maybe we ask you now the right cost.
Currently, at cost, meaning if you buy it from the whoever selling it, the 9-valent vaccine will cost you anywhere from 5,700 to 6,000 pesos per dose. And depending on your age, if you're between 9 if you're 9 to about 14 years old, two doses would be enough. But if you're older than that, you need the standard 3 doses. So you can do the math. So that would be the cost of additional 90 plus.
So here's another question. Why is there a different dosing schedule for 9 to 14 years?
Right. So I mentioned that if the recipient is anywhere from 9 to about 14 years old, maybe even 15 years old, 2 doses would be enough, separated by at least 6 months, but preferably 12 months. The main reason for that is this age group, the immune system is very efficient. If you vaccinated this group, practically 100% seroconversion, very high titers, very effective for this group. Unfortunately, for the older age group, the immune system might not be that efficient anymore. Therefore, the primary target for HPV vaccination, wherever you go, meaning whichever country, whichever population, ideally would be the 9 to 15-year-old girls and then boys. Catch up for the other age groups, both females and males. So you have a publicly funded immunization program. Money is best spent on these age groups. And in the interest of distributive justice, for the other age groups, perhaps we should not be using public money for them. That should probably be out of pocket for the other groups, age groups.
So as of now, is there an age limit? You said that the recommended is 9 to 14 age. Is there an actual age limit? After that age limit, recommended vaccine with the 5 year?
All right, so, good question. If, for example, 3 of us, I guess, are about 40 years old, 45, sorry, 35. Is there a limit to the age group? The regulatory recommendation says no limit. No limit. So they say 9 and onwards, so strictly speaking, there is no regulatory limit. But if you again go by benefit and cost, if you're about 65 years old, you get acute HPV infection, chances are you will probably die of some other disease before you develop cervical cancer. Because as we've seen in the natural history, it takes several years from infection to malignancy. So therefore, your 65-year money is better, I guess, better spent going to Paris or doing such manner. But for our young children, for example, our 9 to 15-year-olds, they still have a long time to live. Money is best spent for their HPV vaccination. Right? So I hope that puts it in perspective as far as age limit is concerned.
We have a question.
We have a question from Cheryl Ricardo. Can patients previously vaccinated with quadrivalent vaccine be vaccinated with a bivalent external vaccine? And how many doses?
I think we've touched on that already. I was saying that whether you receive the bivalent or the quadrivalent, again, the same issues. You can still get the 9-valent vaccine. But if you're more than 15 years old, you still need 3 doses to protect you against the additional 5 strains that were added. If the recipient is 9 to about 15 years old, 2 doses will be sufficient, but they have to be separated by ideally 12 months apart. The minimum interval would be 6 months, but they would recommend 12 months.
We have another question here. How strictly does one have to adhere to the vaccine schedule? 0 to 6 months. A very practical question because for our own development, we think that they shouldn't have first dose because they will not be back and for the second dose. So, and another question, you have to repeat the vaccination if you miss the second or third vaccine schedule.
Again, that is a practical question because the ideal recommended schedule for the 3-dose regimen would be a 1 to 2 months second dose, and then 6 months after the first dose. So it's a 0, 1, 2, and then 6 months. Of course, not all of the permutations as far as interval is concerned have been clearly studied. But if you go by vaccination principles, the principles of vaccination says, so long as you don't give it too soon, it's all right. Meaning, better later than too soon. So it's 0, 2, and 6. You cannot give it a 0, 1 month, and 4 months. The immune response would be suboptimal if you gave it too soon. So if someone missed the scheduled dose, just give the missed dose and then go on from there. You don't need to repeat the series. There is no recommendation to repeat the series. There was a delay in the scheduled dosing. If it's a 2-dose regimen, the ideal would again be 0 and 12 months. The fastest that you can give the 2-dose regimen would be 0 and 6 for any of the HPV vaccines.
We have a question from Dave. How would you address or penetrate religious fundamentals aspect who question acceptability of this vaccine promulgation due to their conservativeness, primarily in a predominantly Catholic country such as ours? So when we introduced the vaccines a long time ago, this is one of the issues that was addressed, and really the vaccine use does not actually promote being sexually active. So it doesn't mean you get the vaccine, you do your thing. So we still advocate abstinence, monogamy, and using safe-sex in preventing cervical cancer and all these sexually transmitted diseases. The thing is, the protection has nothing to do really with regards to the behavior of a person, and we do not assure a person that just because you get the vaccine, you can go and go against your Catholic faith.
Let me add that the recommended strategy in order to avoid getting into that kind of debate with the religious or the conservative sectors is to promote the vaccine as an anti-cancer vaccine rather than an anti-STD vaccine. Therefore, you sort of try to avoid getting into that kind of discussion. And promoting it as an anti-cancer vaccine is really not deceptive because essentially it is really an anti-cancer vaccine. Only the second anti-cancer vaccine, as far as we know, second only to the hepatitis B vaccine. If you put the discussion in that way, you try to avoid the problems about the debates about religion, morality, and all of these other things, aside from the one you mentioned.
So I think this is the last question. This is from Julius Batakan. I think Dr. Manalastas partially answered this earlier, but so his question is, if patients who are sexually active, age group 27 to 30, is it still advisable to get vaccinated?
Some epidemiologic studies have been done on women who have been, both women and men, and the rates at which they are infected with any of the 4 or maybe even the 9 types of HPV. It is estimated that about 70% of sexually active women, but the cutoff is 5 lifetime sexual partners. If you have 5 or less lifetime sexual partners, if you're in that age group, chances of you being naive to all of the 4, meaning 611, 611, it's about 72%. So if you're vaccinating an adult woman who's been sexually active, maybe have had 5 or less sexual lifetime partners, her benefit without testing, without pre-vaccination testing, as far as infection is concerned, her benefit would be about 70% total benefit, as if you're vaccinating a virgin, a 9-year-old naive HPV naive woman. That's about 7. That puts it in a little bit more perspective. Unfortunately, for the other 30%, they might be infected with 1 or more of the 4 types that are in the quadrivalent vaccine. So the benefit would be, of course, much less for them. Because remember, this is a prophylactic vaccine. It does not treat an ongoing current HPV infection. It can only prevent. So that's how you would, sort of counsel patients when they are considering whether or not they could get the vaccine. Now the corollary question is that, could you test for HPV infection, current HPV infection before vaccinating? You could probably do that. The tests are available on an individual basis, not on a mass vaccination program. I said the cost would be very high if you just screen prior to vaccination every month. So on an individual basis, you might want to do that.
Thank you for that engaging discussion, Dr. Manalastas and Dr. Ricardo.
To summarize, we learned that HPV is a very common infection. In 2013, CDC made a statement that around 50% of women and men will acquire HPV in their lifetime. But recently they revised it, saying that at least everyone will get at least 1 HPV infection in their life. So it's higher. So there are different ways of detecting. Going to your doctor and having a pap smear is primarily for screening. But for prevention, there is vaccination against HPV. And Dr. Manalastas has shown slides proving the safety and efficacy of the vaccine. And in countries with very, very good coverage, there is reported high reduction in incidence of not only of pre-cancer resolution, cervical cancer, but also in the reduction of incidence of genital warts, as well as reduction in the prevalence of HPV 6, 11, 16, and 18. With the introduction of the nanovalent vaccine this year, we increase further the coverage. This will provide broader coverage and greater protection to our patients. So after this session, an email containing a survey link will be sent to you. After answering the survey, the certificates will be sent to you. And please answer the survey so we can assess our webinar and address more of your preferences and give you materials from this session. Thank you for joining us. We would also like to thank our sponsor, MSD, for their support of our media partner. Please invite your colleagues to join this continuing 1TCME webinar series. This year's CME webinar series will be held every first and last Wednesday of the month. Please like our Facebook page, it's shown on the screen, for updates, and subscribe to our mailing list for updates on schedules and webinar materials. You may also email us at upnetwebinars2017@gmail.com for any inquiries. On behalf of UPCM Class 1992 and the UP Medical Alumni Society, we also thank our collaborator units, UP Manila Information Management Service, National Telehealth Center, College of Medicine, Postgraduate Institute of Medicine, and Medical Informatics Unit, DOST, ASCI, and Ms. Charisse Marhalo of the UP National Health Center are hosts. This is Dr. Villanueva, Dr. Manalastas, and Dr. Remolino closing this session. We hope you have learned a lot from today's webinar. See you again on February 8th with speaker Dr. Paul Renani, a cardiologist at the Philippine General Hospital, to give us updates on hypertension. Thank you.